All right, so here's a quick outline of what I propose to do. I think some of you may have already heard our talk about dementia overall, but just in case, I'm just going to do a quick review on cognition, function, aging, and then some of the neurocognitive and functional decline. And then we'll, of course, zoom into the big topic for today, which is Lewy bodies. We'll talk a little bit about pathology and diagnosis, treatment, and then touch on caregiving support and future research. So let's get right into it with just talking a little bit about cognition. So we divide cognition sort of into six main areas: memory, which just speaks for itself; orientation, which is time and place; concentration, the ability to focus on certain things and not others. So we get a lot of information going to our brain, but right now you're hopefully focusing on seeing and listening and not so much smelling or listening to other things around your house. Language, of course, the way we communicate; visual spatial ability; and then executive functioning. And executive functioning is really our highest level of functioning, separates us from the animals, if you like. Planning, um, critiquing things, thinking about improving things. Those are all things that are part of executive functioning. So those brain functions allow us to do things. They allow us to do basic activities of daily living. So we learn to dress and wash and bathe and toilet and feed ourselves. And then we learn instrumental activities of daily living, which is sort of how we function in society, like banking, finances, shopping, managing medications, and you see the rest of the list there. And these different cognitive activities can be mapped on the brain. So this is looking at the right side of the brain. And you can see language and hearing are sort of focused on the intersection between the temporal lobe and parietal lobe. You've got vision at the occipital lobe in the back of the head. You've got visual spatial ability. So the vision part is here, and then sort of how it fits into space is here. And orientation to time and place, and then executive functioning. So the frontal part of the brain is the newest part of the brain from an evolutionary point of view, and is our highest level of abilities. And then if we turn that right side of the brain around and look at it from the inside, we can see these structures appear. We've sliced off the left half of the brain, so we're looking at the right side of the brain through the gap. And we have this part here, which is the hippocampus, which is where we do memory consolidation, and then sense of smell is over here. And the brain is made up of neurons, so they have a cell body, axon, and terminals here, and dendrites, which are sort of the input. And we have over 80 billion of those. And the way they work is electricity runs down an axon. It releases neurotransmitters. These cross the gap to the next cell, the dendrite of the next cell. That causes an electrical charge to happen, and then we get the current running through the next cell. And then in three-dimensional space, you can see this cell here. It's sort of lit up like there's a little bit of electrical current. It runs down the axon, it comes over here, and then it lights up this cell, which then would light up this cell, etc. And the connections are, of course, very complex, so that we have 80 plus billion cells, and we have trillions of connections. And recall that it's really important that the brain gets fed both oxygen and food. And essentially, there are two arteries that go into this closed space, and they feed the entire brain. So you can see how there's finer and finer branches that feed the brain, but you can imagine then if a clot comes up here, that eventually it'll hit a place where it can't move anymore, and then it might block the blood flow to that part of the brain, and it could literally kill off a whole bunch of brain cells. So we've talked about aging, and just to summarize very quickly, after the age of 29, we have about 50,000 brain cells that die every day, or 20 million per year, which is about a 10% reduction between the ages of 20 and 90. And there are also changes in the body that affect the brain. The respiratory system changes as we age, and we're less good at bringing in clean oxygen. Similarly, our digestive system change. We might have more diarrhea, might be more constipated. The absorption of different nutrients is going to change, so that the nutrition, the oxygen and the nutrition absorption is going to be impacted. And then there's the whole distribution system, so the whole cardiovascular system, the pump and the tubes, the pipes that feed the brain that can be impacted as we age. And there's decline in all of those things. Just to recap, chronic disease, there's sort of two parts of it. One is it takes a long time to develop. So here you have, someone with arthritis, and we know it takes decades to develop. Typically, there's no cure, so that, we treat the symptoms, so we treat the inflammation, etc. And other examples are chronic lung disease, chronic renal disease, chronic heart disease, and neurocognitive decline is one of those chronic diseases. And so you hopefully remember, if you've seen this picture before, sort of the overlap between normal aging, mild neurocognitive decline, and then moderate to severe neurocognitive decline. In aging, we do have small changes in memory, language, and executive functioning, but really no change in ability to do instrumental activities of daily living. Then we have mild neurocognitive decline, which is there are measurable changes in memory or language or executive functioning or a combination of them, but still no change in instrumental activities of daily living. And then when we get to the moderate to severe neurocognitive decline, right, we have significant changes, and it does start to impair our ability to live independently. And typically, from aging, we can go to mild neurocognitive decline. A number of things can cause that. If we can reverse that, we can go back into sort of a normal aging status. However, if we go from mild neurocognitive decline and start having impaired instrumental activities of daily living, that seems to be irreversible. So if we can catch things early and reverse them, that's sort of the big strategy. And so this is the World Health Organization, and many of you know I'm not a big fan of the term dementia, so I prefer moderate to severe neurocognitive decline. Nonetheless, it's a syndrome, usually of chronic or progressive nature, brain illness affecting memory, thinking, behavior, and importantly, the ability to perform everyday activities. And again, it is an umbrella term, and there are all kinds of things that can happen to the brain that can cause it. And we know that this is a significant issue for Canadians. As of January 2025, there was an estimate of 770,000 Canadians living with a moderate to severe neurocognitive decline. And it's estimated there's about 150,000 new cases every year. So it's a real thing. One way to divide these causes of neurocognitive decline is sort of to look at those that happen within the cell and those that are things that happen outside of the cell. So inside of the cell, you've got these sort of named after people or zones. So Alzheimer's, posterior cortical atrophy, Parkinson's, Lewy body type, etc. These are changes really that seem to be within the cell and then that cause changes in the cell. And then there's things that are outside of the cell that can cause damage to the brain. And we talked about the circulation already, but normal pressure hydrocephalus is a buildup of pressure on the brain, which causes damage to cells. Chronic traumatic encephalopathy, the Muhammad Ali syndrome, like being chronic trauma to the brain, toxins such as alcohol, infections, and then of course an acute traumatic brain injury. And this picture shows how complex really all the factors are that can affect cognitive decline. So it goes from genetics, to mental health, to brain injury, to diseases of the circulation and respiration. And you can see how they're all kind of interconnected. And of course, there's the environment. If you smoke, then you're more likely to have a lung disease. If you have a lung disease, it can cause anoxic brain damage. And so you can see how really it's a very complex system. And even metabolic changes like inflammation can be caused by anoxia, et cetera, oxidation, toxins. And then the socioeconomic factors are not negligible. They're in fact significant, as are gastrointestinal factors as well. So you can see how really it is a complex set of circumstances that cause neurocognitive decline. And then we have the proteins that sort of define some of the different disease types that are sort of embedded in it, and different combinations and permutations of things can happen that result in these protein dysfunctions. So just going to recap how we think about learning, and I use the model of the onion, right? We are born, we don't know a lot, we learn to hold up our head, we learn single words in the language of our parents, we learn to walk, we learn to use the spoon, we follow instructions that are verbal, we don't have to copy the action. We grow our vocabulary, we learn to dress, we make longer sentences, we learn to count, we learn to balance a checkbook, and finally, in a financial, the most complex thing we can do is maybe manage a household budget. And that's great, and that's sort of the normal learning. And unfortunately, when we unlearn, when we have neurocognitive decline and ultimately functional decline, the first thing that happens is typically the last thing we learned. So we might have difficulty managing a budget. Then we'll have difficulty even just balancing the checkbook. Then we have difficulty with simple math, etc. You can sort of see the unlearning and the functional decline that's associated. And just to see what it might look like, so this is a normal brain, a younger adult, and this is someone who's got severe neurocognitive decline, and you can see that this person sort of has generalized atrophy as compared to the healthy brain. And sometimes it's generalized like that. Sometimes there's areas that seem to be more affected. So here the frontal lobe is more affected. This seems not as bad, right? So this would be frontal type dementia, right? So there is sort of large anatomy that can tell us or point to a condition. This is a brain scan, and you can see these white flecks, and they are changes in circulation. So those are microvascular changes. So that was a quick sort of recap of the brain and all that. And now let's go a little slower and sort of dive more deeply into neurocognitive decline with Lewy bodies. So Dr. Friedrich Lewy was born in Berlin in 1985. He was trained in Berlin and Zurich, and interestingly, he did work in Alois Alzheimer's lab in Munich as well. And in 1912, he published a histopathological analysis of what at that time was called paralysis agitans, or what we now call Parkinson's disease. So he took these pictures, he stained parts of the brain in people who had this condition, and he found these changes. A little footnote, which is interesting, is that neither Professor Lewy nor Professor Alzheimer felt that their work was significant later on in their careers. They, of course, published it, and then they wrote books about what they did, but then later on they weren't as sure if it was going to make as much of a difference. So what is a Lewy body? A Lewy body is this is a cartoon. This is this circular thing that's inside of the nucleus. This is a neuron that's at the nucleus, and this here is a Lewy body. What it looks like on a real slide, like this is a real human brain that's been stained, and you can see here this this thing does not belong in a healthy brain. This again is the nucleus. And if we use a particular stain looking for alpha-synuclein, we can see that that really lights up in this person's cell. So when we use that stain in pathology, that gives us sort of the diagnosis of Lewy body type brain disease. So let's go back to our brain and let's look at where we can find these types of inclusion bodies. And so at the back of the brain is one of the areas that can be affected, as can the frontal part of the brain. And it can spill over into the parietal lobe as well. So vision, and we'll talk about that in a second. Visual spatial ability, that's sort of looking at how we fit into the world, and especially in driving, for instance, when you're trying to park, we need to sort of see the space and be able to sort of back into it and fit into it. That would be a visual spatial task. And then executive functioning is all that higher level thinking that we need to do. And we look on the inside of the brain again. Parts where we can see Lewy bodies are here in sort of the limbic lobe and the cingulate, sulcus, as well as in the hippocampus. So we do expect over time that there is going to be some impact on memory, but also on emotion and behavior, which sort of is in this purple zone. So how do we diagnose Lewy body disease? And just before that, let's just talk about a little bit of the epidemiology. So if 770,000 Canadians are living with dementia currently, it's approximately 115 of those would have some kind of Lewy body disease. And of the 150 that are new cases every year, about 20,000 should be new diagnoses. I can tell you from experience that we don't get that kind of rate, and we'll talk a little bit more about why that might be as we progress in the presentation. So the symptoms. So remember, we talked about the visual part of the brain being affected by these Lewy bodies, and the way one of the things it can cause are these visual hallucinations. So a classic patient with Lewy body disease will tell me, or the family will tell me, we're looking out the window and the person living with Lewy body disease points and says, why are there children on the roof of the house next door? And of course, that would be very alarming if it was true, but no one else sees children sitting on the roof. So that is a visual hallucination, right? The person has seen children in the past, of course, but somehow the brain has projected this image of children onto the roof. They will also sometimes say that there's children sitting in the living room, and we'll say, why are their parents not coming to pick them up, and that kind of thing. You can also have auditory hallucinations, but they're a little bit more rare. An important characteristic of Lewy body dementia is its sort of fluctuating course. So Alzheimer's type disease progresses a little bit more steadily. Lewy body has a lot of ups and downs. You might have a couple of good days, and all of a sudden you might have a really, really bad day, and it's fits and starts. Another important factor is what we call Parkinsonism. So it's symptoms that look like Parkinson's disease. So typically you've got the gait changes, so the walking changes. You have more rigidity, so you're more stiff, that kind of thing. Speech can be affected over time as well. Another frequent symptom is what we call REM sleep disorder. Normally, you and I, when we have dreams, our body is paralyzed. Essentially, all of our skeletal muscles go into relax mode. So we can see people beating us up and we will not fight back, because if we did fight back and we were sleeping in a tree when we were, previously evolutionarily, we would have fallen out of the tree, and that would not have been good for survival. Similarly, it's not good for us to beat up our partners if we're sharing a bed with someone. So REM sleep disorder is when we act out our dreams, and it's more frequent in dementia of the Lewy body type. Visual spatial difficulties are a factor. Attention is affected. And then there's this group of autonomic dysfunction, which is more body impacts, where the blood pressure can change. You can show urinary incontinence and dizziness related to, blood pressure or heart rhythm changes. So there's a group of symptoms that can be related to the Lewy body disease as well. So the cousin of Lewy body disease is Parkinson's disease. And in Parkinson's disease, it starts in the substantia nigra, which is more in the trunk of the brain stem, and it involves the depletion of dopamine, and these alpha-synuclein deposits, which we talked about earlier as being a hallmark of the Lewy bodies, they are also found in Parkinson's disease. So you do have Lewy bodies, and the symptoms, of course, are this stiffness, rigidity, tremors, especially that resting tremor, right? That when the hand is at rest, it shakes back and forth. So there's a gradual spread. So you can see here it starts in the brain stem, and then it sort of spreads out throughout the brain, and eventually affects memory, attention, judgment, etc. And we know that about over 50% of people with Parkinson's disease will develop significant cognitive impairment as the disease progresses. And so it's a subtle difference between Lewy body disease and Parkinson's disease. And it really is the sequence of events, so that if you have cognitive symptoms first and then develop physical symptoms, you're more likely to have Lewy body disease. If you develop the physical symptoms first and then later on develop the cognitive symptoms, you're more likely to have the Parkinson's disease. So when we see patients, this is sort of a high-level guideline that help how we think about Lewy body versus Alzheimer type brain disease. And so if we have a lot of short-term memory loss, then we're more likely to think about the Alzheimer type, because the Lewy body, it can affect the hippocampus, as we saw, but that's not its prime focus, prime location. It's only later on. Language issues, there are some in Lewy body disease, but and in Alzheimer's type disease, they do come later on and can be more severe. Hallucinations, though, that this is where we think more of Lewy body type disease than Alzheimer's type. You notice I put little. It can happen. And again, we'll talk about some of the crossover between these pathologies. So it might be that Alzheimer's, people that have a diagnosis of Alzheimer's type dementia or neurocognitive decline, may in fact also have Lewy bodies, and they may be contributing to hallucinations. Nonetheless, if there are significant and ongoing hallucinations, it's more likely to be Lewy body type. Parkinsonism, usually in Lewy body disease, as the disease progresses, you'll rarely get it in Alzheimer's type disease, and same with the REM sleep disorder. So when we think about, as physicians, when we think about the differential diagnosis, these are the types of characteristics that we look for. It's really important to remember, though, that it's rare that a brain will only have one pathology, and so a lot of the time now we'll talk about mixed neurocognitive decline, meaning we suspect there might be multiple causes simultaneously, and you can imagine that if you have a few Lewy body type inclusions in your brain, but then you also have circulation problems in the brain, that will probably compound and make things worse than if you only had one or the other, right? So they're typically compound. And you can see why it's difficult to diagnose, and why we sometimes get, as physicians, we get unsure, and we'll say, it might be this, but it might also be that, because in fact, it can be both. But we sort of try to talk about the dominant condition and then consider the others. But if someone has language problems that are typical frontal temporal type cognitive impairment and hallucinations, which are more typically Lewy body, then that becomes harder to diagnose, and it might be that there's actually components of both. Or if there are more memory problems than we would suspect in Lewy body, then maybe they do have Lewy body as primary, but also some Alzheimer's type things. And then if you add vascular, of course, the vasculars are the hardest to diagnose, because they can affect whatever part of the brain that the circulation happens to have changed at. So you saw that tree of circulation branches, and depending on where the little clot goes, or where the blockages develop, it could be the front part of the brain, the middle part of the brain, the back part of the brain, right? So it could be language, it could be frontal executive functioning, it could be visual. So it's the hardest to diagnose, and then if it's mixed in with something else, it just compounds the complexity. So and we know from autopsies that a lot of the time patients that look like they have one particular type of cognitive impairment actually end up having multiple. So in the case of, if you look at autopsies of people that have significant neurocognitive decline, somewhere between 15 and 25% of them will have inclusion bodies, Lewy bodies in their brains. And remarkably, 70% of those that have hallucinations, Parkinsonism, that have Lewy bodies confirmed at autopsy, 70% of them will also have changes of plaques and tangles. So you've got this, again, this complexity of having multiple types of pathology at the same time. Similarly, people that have mostly memory problems and that have plaques and tangles confirmed, 60% of them will also show some inclusion bodies. So again, the mixed etiology part. And again, we know that normal older adults, when we do pathology and when we do staining of the brain, 25% of them will show some kind of anomaly, in which 10 to 25% of them will be Lewy body type changes. Similarly, 25% will have some type of Alzheimer's changes, etc. So you can see how this gets really complicated and how this mixed etiology ends up being a challenge from a diagnostic point of view, but also from a treatment point of view. Okay, so we've talked about the pathology and the diagnosis. Let's go on into treatment. And I'll just recap something that you would have heard previously, and that's the neurotransmitter that has been sort of the most studied for cognitive disease is acetylcholine. And it is associated with memory. And so there are a lot of acetylcholine producing cells that end up connecting to the hippocampus. And we know that there's a decrease in the amount of acetylcholine in the brain in people that have neurocognitive decline with memory problems. So it was the first target for the production of medications. And so there's three medications that have been developed over the last 25 years or so, almost 30. The first was donepezil or Aricept in 1996. It came out. Rivastigmine followed in 1997, and its sort of special superpower is that it comes in a patch form. And galantamine was, or Remenil was the last sort of out of the gate in 2001. And what's interesting, sort of a historical interest, is that the galantamine comes from the daffodil. And so what's interesting about that is that we know that in ancient Egypt, they talked about the brain power of the bulb of the daffodil. So the ancient Egyptians were already aware that there was something good in that. And of course, like all medications, there's potential side effects from cholinesterase inhibitors. So 1 in 8 people will get some kind of nausea, bloating, diarrhea, digestive symptoms. 1 in 8 will get some kind of problem with bladder, usually more frequent urination, and 1 in 50 will get some kind of cardiac rhythm. And that's pretty easy to explain because acetylcholine isn't just in the brain, it's also on the gut, on the bladder, and on the heart. So we have receptors for acetylcholine. So if we give medication, that stimulates acetylcholine, then we're going to get stimulus not just in the brain, but elsewhere in the body. So, memantine, just to recap, originally treated for, designed to treat diabetes. Later we found it's active in the brain. Not a great medication altogether, but it can be used in more advanced cases of cognitive decline. Importantly, it's not covered by Ontario Drug Benefits. I'm not going to talk more about it, but people can ask questions later on if they'd like. Also, in all cases of neurocognitive decline, the sleep cycle can be affected. So we do have medication that can help us with that. And there's often changes in anxiety, increases in anxiety and increase in depression. And there's a number of medication that we can use to treat that. And so specifically for Lewy body disease, classically, we start with rivastigmine. It has a very flexible treatment regimen. It has a much wider range of active doses than either of the other cholinesterase inhibitors. Unfortunately, we do give it twice a day unless you use the patch, but so it is the one that we typically use for Lewy body disease, but both of the others can be used as well. And as mentioned, in advanced Lewy body disease, we could use memantine as well, although I don't think I've ever done that. The next thing is REM sleep disorder. If you recall, that's when we act out our dreams. There is medication that can decrease that. We can never really get rid of it completely, but if we can decrease the amount of REM sleep happening, then that's a good thing. And clonazepam seems to be quite good at doing that. It is a restricted drug and requires physicians to fill out a special form. Next, if we have Parkinsonism, sometimes we can try medications for that. So levodopa against sort of the tremor and the rigidity. I've had sort of mixed results with that. Certainly not as good a response in my experience as treating Parkinson's disease directly with levodopa. Then we have sort of the more challenging issues, which is the psychological changes, the hallucinations in particular. There is always a lot of pressure to treat hallucinations because they are certainly disturbing for other people. They're not typically not disturbing for the patients themselves. They'll say, why are those children playing on that roof? But it's not like it's causing them a great anxiety. They don't feel like they have to call 911 or anything like that. It's just sort of that's kind of odd. Why is that happening? Or why are there children in our living room? Send them home. And so we'll talk about sort of the approach, but I prefer just sort of living with that and adapting to that rather than treating with antipsychotics. In fact, the potent antipsychotics like Haldol, are really contraindicated in Lewy body disease. So the only one that I feel comfortable using is quetiapine, which is a very mild antipsychotic. And then, of course, we need to manage all the other risk factors for brain disease, so blood pressure, heart rate, glucose, cholesterol. And of course, we always suggest that anyone with cognitive decline, that they stay as physically active as possible, that they do cognitive exercises to keep the brain busy and stay socially engaged. And I understand the difficulty of social engagement, especially if there are hallucinations and and changes in behavior. That can be really hard because we like a restaurant to be quiet and a nice certain atmosphere, and taking people with cognitive impairment to a restaurant is hard, and yet social engagement would be really important. All right, so I am definitely not the expert to talk about caregiving and support, but I did highlight a few things that I think are always important for caregiving, but also in Lewy body disease. So the first is, we know that activities of daily living are impacted, and so the first good thing we can do is, of course, support our loved ones that are living with Lewy body disease, to make sure that the finances are managed, the shopping is managed, that they're still eating healthy, and we want to encourage them, as I said, to sort of maintain physical and cognitive function as much as possible. So when it comes to these famous hallucinations, I suggest to gently redirect. So if the person says, why are those children in the living room? Why haven't their parents come and pick them up? My response to that is, well, we'll make sure that happens. Why don't we go into the family room and watch some TV, or let's play a game, or do a puzzle, or whatever. So it's not it's never great to argue, even though you're right, to argue about hallucinations or misperceptions or delusions. It's just not productive. Their brain is wired right now in such a way that they believe there are children in the living room, and there's no point in arguing about that, really. So it's just sort of redirecting gently and just doing something else and saying, yep, we'll take care of it, and then hopefully it goes away. Of course, it can get more difficult, and the behaviors can escalate. Sometimes, unfortunately, when we have perceptual differences, we may not recognize even a spouse, and that, of course, can become really difficult if let's say the husband doesn't recognize his wife and says, "What are you doing in my house? Get out!" This can really become problematic. So I would always try to de-escalate. So try to tone it down. Don't argue. Just say, "Look, we'll make sure your wife comes home later today. Why don't we play some cards or do a puzzle or watch some TV or anything to sort of redirect?" And sometimes it does require outside help. So sometimes it can help if a daughter that we have a close contact with, or a son that we have close contact with, or even a neighbor that's a really good friend, if they can come over and help settle and say, no, everything's okay. Yep, I'm here. Why don't we go for a walk? And sometimes even that, just going for a walk with someone else and then coming home and going, oh, look, honey's home, and we can sort of reset and hopefully settle down and say, yep, this is my spouse. So that's an important part of caregiving, is trying to de-escalate and get help when we need it. The sort of the normal places to get support, I would say the first line of support is always your family doc, or a care provider. It could be a nurse practitioner, of course. And a referral to the Berea Health Memory Program can help. And of course, the Dementia Society is a big help. Next, I would say if you're having difficulty managing sort of the activities of daily living, Ontario Help at Home, that's their job in society. Unfortunately, there are long waiting lists, and it's hard to get services, and especially regular, consistent services. Nonetheless, if you're having problem with hygiene, there's experts in providing baths, and that's their job, and they come to you and they'll help you with that kind of thing. Then there are things like day programs where people with cognitive decline can go for several hours. Sometimes it goes from 9 to 3, that kind of a thing. They can stay for lunch, and the only thing you really pay for is like the cost of the lunch and maybe the cost of the trip to the event. But that's a great thing, because again, they're around people that are trained to care for this type of condition. And importantly, it gives you, as a caregiver, a number of hours of relief and chance to go shopping and get your hair done or whatever, right? And then take care of yourself. So day programs are great. Respite care is similar, except it's overnight typically. So let's say you have a wedding to go to, and it's going to be too difficult to bring your loved one. Then respite care can provide a place for them to stay for a short period of time, let's say a couple of days or 3-4 days, and the care is provided, their medication is given, etc. And again, that gives you a chance to recharge the caregiver battery. If none of that is enough, then there's the possibility of retirement homes, especially ones that have memory care units or at least assisted living. And ultimately, of course, if it becomes too difficult and they require many, many hours of care all day long, then long-term care would be sort of the ultimate destination. And I'll just very quickly and just very briefly touch on sort of the future in the space. In all neurocognitive decline research, there's sort of identifying early on subtypes and then sort of being able to customize treatments is sort of the principal thinking right now. So biomarkers means typically blood tests or spinal fluid tests. So looking for markers in fluids. Imaging, of course, is taking various specialty type scans of the brain. And then, of course, there's remote monitoring as well, which is sort of behavioral monitoring that can be done using technology in the home. And so from a diagnostic point of view, that's sort of where the research is going right now. On the treatment side, you might have heard that lecanemab has just been approved by Health Canada. So this is a disease-modifying therapy, so it's not for people with Lewy body disease, but it's sort of they're working on the same kind of thing for Lewy body disease. There's targeted drugs, so these are pills that you would take that would affect, just like the ones we have right now affecting acetylcholine. These are sort of affecting the disease process. Autonomic symptoms, so anything that can support blood pressure and that kind of thing is actively being researched. And then in contrast to all of these things, which are highly specialized, there is a whole set of research right now looking more holistically at caring for the brain. So it involves exercise programs, diet, cognitive training, and that kind of thing. And so that is a whole area of research right now as well. So I'm going to very quickly do an advertisement. We are always looking for people that are willing to participate in research projects that we're running at Briere. So we have a phone number here. We also have an email address if you would like to reach out. And I think that's a wrap for now. I'm happy to take questions.
Perfect. So thank you, Frank, for that great presentation. So let's see if we have any questions. So there's a function on your screen for the Q&A box. So if you want to pose a question to Dr. Knoefel on Lewy body dementia, so just a reminder that please don't share any personal data or health data, and we'll be happy to answer those questions live here from the crowd. Well, in the meantime, maybe I'll get some of the questions we received from caregivers in the past with regards to Lewy body dementia. Um, so can you explain more about the Parkinsonism in Lewy body dementia compared to Parkinson's disease?
Right, so the symptoms are actually very similar. It's just sort of the sequence that's different. So one thing I haven't found a lot in Lewy body is the sort of that resting tremor, right? This thing that you see typically in early stages of Parkinson's disease. I don't see that very often in Lewy body disease, but the other things, sort of that rigidity, right? So like if I want to put on a sleeve, like put my arm in a sleeve, like it's really hard. Like my arm is stiff, and someone who's trying to dress me will be fighting this stiffness. And similarly, like to get up from a chair, right? We need to be smooth and bend over and lean over and change our posture. So that becomes much more stiff, and we sort of have to lift the person up. They sort of keep that's kind of bent position for a long time and then slowly kind of straighten out. So that kind of rigidity is also frequent in Parkinson's disease, and it is frequent in Lewy body disease. And then you have that shuffling gait, so those small steps, and sort of the we call it sort of retropulsion when you're trying to get up. So you're trying to get up and you can't sort of fix your center of gravity, so you fall back. But then when you're walking, like you sort of lean forward too far and you can't take steps fast enough, so you get sort of that frontal fall as well. So Yeah, so the Parkinsonism that's common is the shuffling gait, the stiffness. The thing that's typically different is sort of that resting tremor.
All right, perfect. So I have another question here. So is Lewy body dementia genetic?
Right. So there is no right now there is no sort of single gene that we're aware of, and when it comes to Lewy body disease. Having said that, um, there seems to be a little bit of increased risk if someone in your family had a Lewy body disease or someone in your family had Parkinson's disease. It seems you have a slightly greater risk of having a Lewy body disease yourself. And it kind of makes sense, right? If there's a predisposition, it's sort of like arthritis, right? My dad has arthritis, my grandfather has arthritis, and I'm starting to feel it in my hands as well. So there's an increased risk. It doesn't look the same necessarily in my hands as it does in my dad's hands, but there you can see there's sort of a predisposition. And in the same way, it's definitely not like eye color where you only get the eye color you get from your parents. In this case, it's much more complex, but there is an increased risk. If you have someone, sort of a direct family member, there is an increased risk.
Okay, so has anyone done any research on the use of, I think it's CBD on dementia?
Yes, so there is ongoing work on CBD in dementia, and so yeah, the CBD is the um, sort of the anti-anxiety part of marijuana, and there is some work that's been done on it. Right now, it's still anecdotal, but I know there are a couple of clinical trials that are happening right now, and we'll have to see. I mean, at this point, um, my approach to patients is, I'm not going to prescribe it, but if you want to, buy it yourself and you want to try it with, a couple of drops under the tongue, and then, we'll see how it goes. It'll be sort of a bit of an experiment, but if it can help, then, I certainly don't have anything against it. Anything that can help with anxiety, I'm all for. The problem is if you get CBD that has too much THC in it, the THC is the one that causes the hallucinations and the paranoia. That's the last thing we need for someone with Lewy body disease who's already, having difficulties interpreting things going on around him or her. That would be, I would want to make sure that there's no THC at all in the CBD, and so you'd have to have a trusted source, and you'd want to make sure that it says 1% THC or 0.5% THC. I wouldn't want much more than that.
Perfect. Yeah, so the other question is, I think it's, well, you mentioned already that lecanemab has been approved by Health Canada this week. I think there's probably a question that people might have is whether this medication could help in Lewy body dementia or not, and why in Alzheimer's and why not in a Lewy body, for example. I think that's something people will come up in the future, or maybe asking now
Yeah.
themselves.
Yeah, so I mean, lecanemab, its specific role is to help remove amyloid from the brain, right? So it's really antibodies, synthetic antibodies that we run into your veins in your arms, and those antibodies go all through your body, but end up a lot of them go to the brain, and there they identify amyloid, and then the way the immune system works is when it sees an antibody stuck to something, the cells go and chomp away at this thing. So let's say you have a virus, the antibodies stick on the virus, and the cells come and chew up that virus and hopefully destroy it, and then you get better, right? So that's part of our immune system. So here with these biologicals, what we're doing is we're sending antibodies into the brain against and lecanemab, specifically the amyloid protein. with the idea that hopefully then the immune cells in the body will be able to help clear out the brain. And there's some evidence that that works, and some evidence that that can help the cognitive process as well. So the problem with Lewy body disease is if you have pure Lewy body disease, then your protein problem is the alpha-synuclein protein and not the amyloid protein. So giving you a treatment to remove amyloid won't be useful. Having said that, we know that over half of people with what we call Lewy body disease, because they have the symptoms of Lewy body disease, we know that half of them will have amyloid deposits as well. What we don't know at this point is, who is sort of the ideal candidate. It's going to require a lot more research to figure out if you have 2% amyloid, is that enough to be treated, or if you have 10% amyloid or whatever. So those are questions that will come in the future. For now, and to be clear, it's not available yet in Canada, but it is approved by Health Canada. So now provinces need to decide if they want to put it on the formulary, and if it is on the formulary, if they want to fund it. So there are still a number of steps to do, but at Briere, we're certainly getting ready to be able to provide this as a treatment. And there's a lot of unknowns at this point, but most likely we suspect that it's going to be for people that are early on in their cognitive decline, and they have a very strong amyloid presence, and so it's going to be probably younger people, and with early mild cognitive decline, most likely, or very early stages of functional decline. So there'll be strict criteria around who will get it most likely, and then the cost, it will be the wild card, because as of right now in the US, it's $25,000 US a year just for the medication. That's not the cost to administer it from nurses, and not the cost of brain scans you have to do to monitor the brain as part of the sort of follow-up. So yeah, so at a high level, I guess that's the short answer. For it would not be for people with Lewy body disease at this time, and I suspect it would take many, many years before we can sort of spill over from what I would call pure amyloid type disease to others that have a mixture, and what proportion of mixture we might be able to try it on.
Perfect. Well, thank you so much for that answer. That was, I think, a lot of people were having a question this week, and I also have let's go through three more questions here. So one is, what is the average life expectancy of someone with Lewy body?
That's a great question. So, the way I answer it is this way: if we think about someone having cognitive decline that's impacting their function, usually that's when we diagnose dementia, right? Neurocognitive decline with functional decline. From that point on average, we say it's a 10-year life expectancy on average, meaning some people are going to be less than that, and some people are going to be more than that. Typically, Lewy body disease seems to be more dangerous for your health, with the decreased mobility, with the bladder problems, with the increased falls, with the hallucinations, and then the difficulty managing all these things, the earlier entry into institutions. It seems to be shorter, and so I'm not going to say it's it's X number of years, but in my experience, it's certainly quite a bit shorter than the 10 years. That's the average. So and again, and part of going to a specialty clinic is that, we can work through that together, and the faster it goes early on, the chances are it'll keep going faster, and we can sort of predict based on what's happened so far. But it can be pretty fast. I've seen 5 years.
Okay. So it is possible in very early stage of the disease, Lewy body disease, to have hallucinations before any other symptoms arise.
Yeah, certainly, it's possible. So remember that we start having these changes in our brain, we believe, in our 40s, right? So if we're going to have significant cognitive decline in our 70s, let's just say, I'm just saying, making that up, but we believe that those changes start in our 40s. So at some point between 40 and 70, and when we make the diagnosis, and I know that obviously we make diagnosis before the age of 70. I'm just saying as a average or whatever. That somewhere along the way, these changes are going to be enough to cause symptoms. So the most frequent early symptom is the REM sleep disorder. So we will see people who will have REM sleep disorder a number of years before they seem to show the other cognitive declines. So, but it certainly is possible to have hallucinations earlier, and especially if it's linked with another health change. So if you have, the precursors of Lewy body disease in the back of your brain, and then let's say you have an infection and high fever, well, then that can trigger changes in your brain that might cause a hallucination. So what we call delirium, sometimes when we get delirium and we go, well, that's weird, why does this person have a delirium? He doesn't seem to have any other signs of dementia. It might be that there's just enough change in the brain that has accumulated over the last couple of decades that a fever or something like that could cause it. So yes, it's possible to have hallucinations before anything else. I'd say it's typically associated with some other health condition, but yeah, that's a great question.
Okay, so last one is having a predisposition or getting dementia due to genetics. How early could someone get diagnosed?
So I'm not sure I understand the question correctly, but I think what the person is asking, if my direct relative, let's say my mother or father, has dementia, and I am worried that I might get it, how early can I be tested or diagnosed? Is that how you understand that question?
Yeah, I think so. Yeah.
Okay, so so there's sort of two parts to the answer. The first is there are extremely rarely, but there are families that do have a particular broken gene that causes dementia. So if you have a grandmother who developed dementia at 50, and then 4 of her children developed dementia at 50, and of those children, half of those children develop dementia at 50, then you've got a very particular familial type of dementia, and that can be tested at a place like CHIO. CHIO is sort of the Ottawa Genetics Center, and that can be tested early. Like if 50 is the trigger date in your family, then you can have the testing at 25, right? But that's not sort of what we see 99% of the time, right? We see the more one-off type dementia. So what I would say to you is, if you have a family member that has, diagnosed neurocognitive and functional decline, right, that you have an increased risk, and that you should immediately start doing the best you can for your brain, right? So stop bad habits like smoking and drinking and eating too much red meat, and start doing good habits like physical exercise and cognitively stimulating activities, learn a new language, learn a new musical instrument. So do everything you can to keep your brain healthy. When you start showing measurable change in cognition, then go see your family doctor, right? And they will either do a memory test or refer you to a memory clinic like ours, and then we will manage it from there. But as of right now, it um, the standard of care is that we recommend the best brain health activities we can for you, and you keep doing those for as long as you can, and only when real problems start developing, then we start doing more invasive testing and that kind of thing. So I hope that answers the question.
Okay. Well, let's talk about this one just as last one. It is possible to have Lewy bodies without the disease, and it's normal to have them due to age.
Yeah, so that's the big unknown, right? So I talked about that on the previous slide where I showed that, somewhere between 10 and 25% of older adults, when they die and we do an autopsy on their brain, they have Lewy bodies, and yet no one ever said that they had memory problems, that they had hallucinations, or they had mobility issues, or any kind of Lewy body disease. And as I said, we believe at this time that this condition starts at the age of 40. So from 40 until, whatever, there are going to be decades with no symptoms, and yet brain changes that would be, described by Professor Lewy in 1912, right, when he published that paper. So we have not had research where we have been able to identify people with, let's say, Lewy body changes on the brain, um, a bunch of them, and then follow them for 10, 20, 30, 40 years. Because, well, it's hard to test for Lewy body disease without an autopsy right now. But let's say if we use the Alzheimer type disease, right now it's not standard practice in Canada to do PET scans that look for amyloid. But what we would need to do is take 1,000 people, do PET scans on all of them. If we get 200 of them that end up being positive, follow those 200 people for 10 to 40 years and see if what percentage of them end up having the symptoms of clinical Alzheimer's type disease. So we haven't been able to do that, but we do know from some studies that if you do have these changes in your brain and they're detected at a certain age, as time progresses, you're more likely to develop cognitive symptoms than someone who has a completely clean brain, none of these changes. So that doesn't mean that if you don't have amyloid, you're not going to get dementia, but if you do have amyloid, it looks like your risk is increased, and over time, yeah, but no one has been able to do the study, and it would be a very expensive study because it would have to take 40 years. If we take a whole bunch of 50 or 60-year-olds and then follow them for 40 years to see, does everyone who has amyloid get memory problems of the Alzheimer type? And does everyone with alpha-synuclein develop either the physical symptoms of Parkinson's disease and or the hallucinations and symptoms of Lewy body disease? Yeah, we just don't have that information yet. So absolutely, it's possible that if we look today, you might have changes in your brain of one or the other or both, and vascular changes, right? And you might be cognitively perfectly fine. What we don't know is if in 10 years you'll still be cognitively fine.
Okay, well, It's 6:15 p.m. So thank you everyone for joining us today. Thank you, Dr. Knoefel, for that great presentation. For everyone, thank you for all the questions. I think it was a very informative session. So don't worry, this session is being recorded and it's going to be posted on demand on our YouTube channel, so you can watch it again and review all the facts about Lewy body dementia. So with that, I think we'll have to, I wish you all a great night and stay well and stay in touch. Have a good night.
Good night.